All right, shall we continue to our second session of more TR, our TR squared, innovations and cases. And it's a great pleasure. I'm moderating with Gorav, Ailawadi, and a great panelist already to my left, Richard Bay, to my right in red, Roosha Parikh from New York, and of course, Paul Sorajja, and our favorite from Chicago, Mark Ricciardi. And without further ado, let me welcome Dr. Hursh Naik, who will present to us this tricuspid case changed me.
Thank you guys for allowing me to go early because I'm going to run and catch a flight right after this. Appreciate that. So, when they asked me about what changed me, I was like, I went through cases in my head, and, you tend, as operators, we tend to, I think one of those golfers said it. It's like, when you win, it lasts for about 2 minutes. When you lose, it lasts forever, right? And so that's what I was thinking. What are my bad cases that happened to me that, and that's what really kind of starts change, right? And so that's, I'm going to show you that case. So this was in 2019. So when we started the Triluminate trial, we had to do a couple of roll-ins. I don't remember, Paul, if it was 1 or 2. But we had to do a couple of roll-ins, and this was a roll-in patient. Okay, so 81-year-old female with fatigue and shortness of breath, no other cardiac history, found to have severe tricuspid regurgitation. And so here are the images that we kind of present to the committee. So severe TR. I still just say severe. I'll let the smarter people behind me talk about 3, 4, or 5. Okay, that's still severe. And it was considered a good case. As you can see here, there's good interseptal leaflets. So we decided to go ahead and perform transcatheter edge-to-edge repair. So we used an NT. First clip position was an NT at the anterior septal area near the commissure. Okay. And so you can see here in the transgastric view, the anterior septal leaflets look really good. And it's at the commissure, so we're probably just going to keep on moving up to the mid area. So here's the second clip. You asked me what changed me. So stay tuned. Yeah, this is they're all the NTs. And remember, we were thinking, I don't know if you guys remember the conversation, since the leaflets, you can see your finger behind a leaflet, a surgeon can tell me better, but you can see your finger behind a tricuspid leaflet. So we thought they were frail and thin, and maybe grabbing too much with an XT can cause some problems. And there was some discussion about that. And these are the kind of fun discussions that happen when you don't know anything, right? And you need the data to support it. So I thought, we'll roll in, let me put an NT because I think that's a little safer. A little more difficult because the leaflets are long, but I thought safer. So here's the third clip. So look at the third clip, and you guys can tell me what you think is wrong with this, but a couple of things. I thought I had the septal leaflet, and especially with an NT, we measured that over and over again. And then the anterior leaflet, this is probably close to the canyon, which wasn't really a word in the beginning, and then it became a word afterwards when we started realizing what the canyon meant for when we were treating it. But you can see here, there's probably some stress on the anterior leaflet. The papillary muscle is kind of what defines that AP canyon, or kind of that starts the I guess conversation about AP canyon in the tricuspid valve at that point. And you can see that there's a little stress. And this is also 2020, hindsight's 2020. So, and this is what it looked like after we released it. And the TR was trace mild. And then this is what it looked like about 5 minutes later. What do you guys see? It totally flipped me off, for sure. So so I think it came off. I think it came off the septal leaflet. So even though that septal leaflet looked like it was the worst, I think it came off the septal leaflet and it's just flopping around on the anterior leaflet. And one of the things I learned from this was, when you're near the AP canyon, probably the best thing to do is have more stress, if you're going to have stress, more stress on the septal leaflet, even though it might be tethered, grabbing that first and really bringing it over as opposed to the anterior leaflet and causing stress on that side. And so I think the septal leaflet kind of just ripped. So the patient was very stable. So we ended up putting a fourth clip. There's another thing I learned. Now we put it at the posterior septal. Then this is what it was, he was asking me what changed me. This is what changed me about that AP canyon is that I'm not going to go directly for that jet there. I'm probably going to go a little bit to the posterior septal side next time, which we did here. And a couple things happened. We stabilized this clip. We see we're at the posterior septal orifice. The SLDA movement is not that much. And here's our result. So I saw this patient, and this is our result about 30 days later. I saw this patient, too bad she's not in the trial, because I saw this patient about 3 months ago. That's like 5.5 years later, and she's doing great. And the echo looks the same. And that's the, people ask about the gradient afterwards. I've never had a high gradient, but this was about 2 to 3 after the clips. Thank you. Oh, here's how it changed me. Sorry, you can, I don't use any more NTs. So that's the last NT I ever used. And beware of canyons. Thank you.
Great case, Hursh. And I think maybe Paul as well, and your comments as well, Hursh, in terms of the type of clips now we are using. I'm pretty sure we've, like your case, no more NTs, and majority of them are the XTWs. Any comments on that, both of you?
Yeah, I mean, I'm strictly XTW, and I mean, the more we did this, we realized even if all the jet is at the PS segment, you probably want to put one XTW at AS just for stabilization. And what I think people were talking about earlier is framing the tricuspid valve. But I'm strict XTW. I might still end up with an XT sometimes as the second or third clip, but definitely XTW to start.
So I'm going to take a little bit of the blame of why you probably started with NTs. So in the beginning of the trial, we actually had a lot of concern with long devices because in the EFS, as well as some of the off-label work, the XTs and XTWs were twisting the valves a little too much. And so there was this fear that starting with bigger devices would grab a lot of cords and pinwheeling would be more accentuated. So where appropriate, we were trying to encourage people to use an NT because we felt that, well, in the EFS, you can get a pretty good result with an NT and it'd be safe. Remember this, Richard?
Yeah, that's what I was going to mention. In the beginning, we were all NT and made my life harder, but yeah, it was...
Yeah.
I do want to make a comment about your point about seeing through the leaflet, and I do think that we probably can get better at imaging and trying to understand, because we do occasionally see myxomatous-like, tricuspid valves, particularly those that have atrial FMR. They've had AFib for a long time. They actually get more of a thickened leaflet, and that will hold it'll hold sutures, it'll hold clips very, very easily. And so, I think a normal tricuspid valve, you're right, it's very thin, very pliable, and at risk. And I think the other thing that we've all learned over time is just how to manage the clip when you're starting to close it to avoid stress. As it comes up, you can put a lot of stress, particularly with an XT. And so, the maneuvers to advance at minimizing those risks, I think we've learned a lot better how to do that. I have a question for you though. So 4 devices, duration, so it sounds like it's durable, but for operators that are doing it, maybe less experienced, how long did that case take? And at what point do you say, I'm going to do enough, it may be a long case, and come back to live another day? That's obviously the nice thing about the tricuspid valve. There's not much harm. You can see how it goes.
So I could have lived another day with this one, except I didn't know what the natural history of an SLDA was on the tricuspid valve, which I was
almost forced to then.
Yeah, so
but if the SLDA was in the one in between.
Yeah, maybe I would have left it. If they're hemodynamically stable. So that's one. The time, if you look at it's unfair to quote this data, but if you look at the data from the Triluminate trial, they weren't experienced TriClip operators, even off-label, but they were experienced MitraClip operators. So I bet you that helped with the time, the lower time. But it wasn't a significant time to clip, and there are actually more clips in the tricuspid valve than the mitral. So I think this is, and it was very safe, as you know. So I think this is, if this was your first case, I'd be a little reluctant, but 5, 6 cases in, I think this is very teachable.
Yeah, it's an awesome outcome, all things considered, for sure. So is it fair to say, and I do remember, I'm glad you took a little credit for the NT versus XT thing, because I was gonna bring it up if you didn't. Never a role for NT in tricuspid tier. I mean,
Who in the audience when's the last time anybody put an NT in a tricuspid position? Has anybody done one in the past year? So there's your answer, Mark.
Yeah.
I can't remember the last time I put an NT in. Nadira, Richard? Who from Abbott is here? Where is his? Nels here? I saw it. Nels, who? Yeah, Nels, how often are NTs, NTWs placed in these tricuspid positions? Less than 1%. What?
He's like, why did I call him?
I see where this is going.
I can't remember.
So pretty rare. Pretty. Okay. All right. Well, then I'll take it. I'll take it. But I do think we have to be careful. To Gorav's point about how thin these are. If you don't need a big device, you shouldn't use it, because these SLDAs, these are tears. These are not just simple leaflets coming out. I really think these are tears.
Yeah, I think that's a good point. They are tears. I mean, and then now you're really stuck, because even putting additional devices adjacent may not. You have a disruption in the integrity of the anterior leaflet or the septal leaflet. So, but I think we can, with imaging now and, with future technologies and AI, can probably predict what type of stress will occur based on sort of the annular dimensions, the amount of leaflet you have. And I think we can get a lot more in the future smart about, even which device and where to place it.
The other thing is, as this therapy has become popular, we were treating mostly atrial TR, right, in the trial, but now we're starting to find primary TR, which fascinates us, right? Because when you see primary TR, you're like, you know what, we weren't seeing these patients before, but now they're coming to us. So I wonder what the clips are going to act like in primary TR, because we haven't really looked at that very closely.
Primary TR is like a mid-right coronary lesion. I just salivate when I see them. Yeah, because you got thick, mobile leaflets. You have a lot to work with. I really get excited.
Too.
Yeah.
Great. All right, I think we're going to move on. Thank you so much. That was a great case and sharing your learnings. Next, we're going to hear about tricuspid masses and percutaneous removal. Abdallah Sabbagh. Thank you.
Hi, good morning, and thank you to CVI and to the organizers for inviting me back to talk about one of my favorite topics, which is a tricuspid TRIM, transcatheter removal of intracardiac masses. All right, so this is an 80-year-old female presented with an incidental finding of a tricuspid cardiac mass. She has a history of some radiation focally to the chest, squamous cell carcinoma resected, and then suspected renal cell carcinoma on a recent CT scan. And this is her transthoracic echo as well as the CT scan. So it showed a suspected mobile mass with an attachment to the TTE thought it was on the RV free wall. The CT thought it was on the ventricular side of the tricuspid valve. And so the TEE was pretty descriptive, I would say, that it was suspicious for papillary fibrillostoma. I don't know if the imagers here want to comment.
Roosha, any comments?
I mean, we see a mass. I don't know, just based on this TE, if I'd say it's a papillary fibrillostoma, but you see the stalk, you see the uneven edges.
Correct. So a very nice stalk, and then the pom-pom appearance. But this patient has also a history of cancers, etc. So we decided there's been a small series, an observational study that showed that these right-sided PFEs can lead to recurrent PEs. And then we also wanted the tissue for diagnosis given her history of malignancy and whatnot. But it really is suspicious for PFE. So how do we approach these masses and these cases? So we look at three things: the mass characteristics, what's the consistency, what's the stock, what's the attachment, what's the mobility. We match those with devices, and now we have multiple devices, and we try to, patch things and MacGyver things. So we use aspiration devices. There's the Ono basket. There are snares that we connect to RF ablation. There's obviously bioptomes and whatnot. So we're really patching things together to remove these masses. And then we look at the patient characteristics. So if there's a patient with active valvular heart disease, and we use an aspiration technique, so we may have to be careful about the hemodynamics. So we're really matching these three categories to pick the technique and the approach. Now, for papillary fibroblastomas in specific, they tend to be very mobile. The stalk tends to be very firmly attached. Sometimes it's not as attached, but most of the time it's pretty attached. And they tend to be very soft, and I'm sure our cardiac surgeons can comment on that they can fall apart if you just pick on it. So when we started doing these percutaneous removal of these papillary fibroblastomas, we learned three lessons the hard way. Lesson number one: if they're small, it's very difficult to remove. Can't image them, can't snare the stalk. Very difficult. Lesson number two is if we just aspirate it, remember the stalk is firmly adhered, and if we just applied aspiration, we can make the PFE smaller. It's still attached, but it's smaller. We just pretty much trimmed the top part of it, and now we're back to problem number one. We can't remove it. This is very difficult. And then some cases here and there show that if you use non-continuous flow aspiration devices, that sometimes, again, it can fall apart because it's so friable that it can embolize, and so it has high embolic risk. So the technique that we've committed to in these PFEs is using continuous flow aspiration with angiovac. So we turn on the flows at low speeds to lock the mass in place. Then we try to slide a snare across the stalk of it, tighten the stalk, ramp up the speeds of flow, and cut the stalk with RF ablation. So you can connect actually the gooseneck snare to RF ablation to a Bovi, and just 70 watts, and it cuts very nicely and cleanly. Here's an example. Most of the experience before this case was in the aortic, just given the prevalence of this mass. It's on the aortic valve and on the left side of the heart. So here's an example of the technique on the aortic valve. I'll go back to the case here just shortly, just to demonstrate to you that what we do is we open the snare, we explain through the snare, we see it in two views. If you can see here the left top part, then we slide the snare slowly until it's at the level of the stalk. We tighten the stalk, and then you can see here at the bottom picture, the blue arrow. This is what we see with when the snare is tightened and the leaflets are still moving. This just kind of gives us some reassurance that we're not interacting too much with the aortic valve. And then we do an RF cut with the hot snare, and you can see the PFE on the right side. Now back to the case here. So we decided to do the same, angiovac from the IJ, and there's a 3D print here that's going to be circulating. It helped us with the planning. That mass was under the tricuspid valve on the septal leaflet. So an IJ approach with the aspiration was felt to be the best approach, and then trying to snare it from the femoral vein, and then using TE and ICE to guide us. Access, we can discuss large bore access from the IJ, but what we do here is we pre-close with a figure of 8. Some use per closes, but we do the figure of 8, and then upsize to the angiovac, and we assemble the outer and inner funnel. Following that, we try to align the angiovac funnel with the mass. This is the TEE. We used ICE, and we use NPR too. We learned that from Nadira. So it helps us align the angiovac with the mass. Once it's aligned here, we as I mentioned earlier, we turn on the flows at low speeds to lock the mass. So you can see here the top, the TEE, you're going to start seeing bubbles. That's when the flows are turned on. And you can see the mass stand up that's when it's kind of locked in place. So it helps with two things. Just reduces the mobility to help us snare. And if there are fragments that come loose, they get pulled into the funnel. But the tough part of the procedure was the snaring aspect of things. Because visualization, again, with tricuspid interventions, right? Anything under the septal leaflet is a nightmare. So we tried multiple techniques. We tried to snare conventionally from above. And then you can see here in the middle fluoroscopy, because we cause some TR, the snare gets pulled into the RA. We tried to sweep the snare from the RV apex back up, could not snare the stock of it. And predominantly it's because of the visualization. It was very, very difficult. And we tried TEE as well as ICE. And it was very, very difficult to see here. This is exactly the image we tried to get. And you can see hints of the snare. You can see the circle is the angiovac, and the dot on that short axis is the snare. Very, very difficult to visualize. But when the next step, we thought there was just too many moving parts. We had the funnel, we had the snare, we had the TEE. So we decided maybe let's just bunch the equipment together to see if we can get one unit, which is the catheter system, and one unit, which is the echo system, the imaging. So we wrapped the snare around the angiovac, and then aligned the angiovac with the snare wrapped around it, aligned it on the TEE, and then tried to, once we had the mass pulled into the angiovac, tried to slide the snare over it to wrap the stock of it. We came really close. You can see here the TEE on the right side. You see, we came really close, and then once you start closing it, it's an imaging, but it's also a feel. We got really close, but couldn't get it. So things became personal, and so we decided let's just wrestle with this, just with pure aspiration and see what happens. And so we just aligned it again, and just ramped up the flows of speed. You can see on the top right, the PFE getting pulled into the funnel, and you can feel it with your eyes, right? When I mentioned to you that the attachment is firm. That's a firm attachment. So just with high flow aspiration and maneuvering the angiovac, again, literally wrestling with it gently, but we were able to pull it out successfully with no injury to the valve. And here's the fun part of the procedure. These are acute masses. When they come out, and they come out of saline, they come out mucoid. So sometimes you can miss them if they're small. And then when you put them in saline, that's when they blossom and they become, they get that appearance of the sea urchin appearance, as you can see here. So pathology obviously turned out to be PFE, and the patient was discharged the next day. So with that, I'd like to thank you all for your attention.
So, yeah, congratulations on sharing. Maybe just a broader view, since it's certainly new to me and maybe a few in the audience. What's been the total experience that you've had? What's your estimate about the total experience? What other skill sets do you think are needed to move from what most of us are doing, traditional transcatheter procedures, to doing these types of things?
Yes, no, absolutely. So, the experience has been in the teens. Obviously, it's not still a growing experience. The surgery is still the standard of care. When I started, many of them were the small ones that none of them I could not remove any of them. So now I just focus on the large ones, and so that it's now definitely a growing experience. As you can see, I mean, we put the TEE probe in many of these structural cases, and we now find them incidentally. So we're finding more and more of these incidentally. So I think that this is only going to get more and more. The skill sets is the building blocks, right? Whatever we learned from structural interventions and tricuspid interventions, aortic interventions. So just patching things together. It's just these different skill sets. But this is a space that needs innovation and needs better imaging.
And then how are you deciding between surgery versus, is it anatomic? Is it based on the patient? Is it based on concomitant things? How are you deciding?
I mean,
which
surgery
approach?
is still the gold standard. I mean, for us, it's still but if they're in high risk, that's when we decide.
Great presentation, Abdallah. I mean,
Thank you.
for those of you who don't know Abdallah, I mean, I learned a lot from him. I think of him as the king of percutaneous mechanical aspiration together with Sanjam. They're really leading the charge in the country, I feel, and there's a paper out, I think, right?
Yep.
Who just got, so congratulations.
Thank you.
Putting the group together in the country on percutaneous mechanical aspiration. I learned a lot, and thank you for all your work. Like you say, how do you encourage people in this audience in terms of starting up this mechanical aspiration in their sites? Any advice that you have for them?
Definitely. Start on the right side. Get comfortable with right-sided aspiration. Obviously, take all the skill sets that you learned from the structural, peripheral, and then go to the OR, actually, the first couple of left-sided cases especially. I went to the OR to feel it, just understand the consistency of these, and then, again, just get a great imager, because that's what makes or breaks the case.
Abdallah, can I just ask, so technically when you did this, did you have the snare cut the stock, or did it just come out?
It just came out, but so it just took a little bit of pushing in and out just to cut it with the funnel tip.
So
of the
as an
angiovac.
operator, I think probably the way to approach this, if I'm understanding how you present it, is just start with the snare over the angiovac.
That's what I would do next time.
Pull the mass into the angiovac, and then slide the snare over it. And if mass comes by itself, great. If it doesn't, close the snare, RF it, and then it should come out.
Yes, if it's in a tough spot,
Yeah.
yes. But for the aortic ones, I snare separately. It's just
snare.
easier to navigate and image and handle.
It's kind of like using the angiovac's like a pickup. It's like using it like a pickup to
Correct.
essentially pick up the mass and then scalpel behind it. It's kind of the technique is that what he's describing.
Yeah, I think that's right. Your point about the tissue quality is also important, and I know that's really hard to tell. Even we can't tell until we're in the OR. Like a myxoma is very different, right? It's so fragile. It's like a raspberry, and it can just shred on you. Whereas an elastoma can be a little bit more hardy. At least it's not going to shred into all those pieces. Can you get a sense of that? I mean, or are you just relying on your imagers? And maybe the imagers can also answer that question. How comfortable do you feel? Maybe we need MRI on everybody, but a little bit more insight on that.
So we're starting to understand, obviously imaging is very critical, but even these myxomas and PFE, some of them are more chronic, like the calcium deposits, et cetera. Those tend to be a little bit firmer than, if it just popped up a month ago, there was nothing on the, 3 months ago, there was nothing on the echo, and now you see a big thing. It's going to be probably a little bit more friable.
Basket?
For the PFEs, again, I don't want to, the continuous flow gives a little bit of a buffer. If it falls apart, it can be pulled in, whereas if you're trying to just mechanically pluck it, it may fall apart on you. That was my concern.
Just a quick question. So since you had ice already in there, these masses in the RV, have you ever advanced the ice into the RV to get
Yeah,
visualization?
we tried. It was very difficult. We did try that.
Is open surgical repair kind of your backup if things go south, or do you also have a backup plan for a TTVR for, those inoperable cases?
Yes, we have transcatheter backup. I always involve them. I give them a heads up. We do CTs on all of them for, either evoke or get the clip group on board. So definitely. I've had it on the aortic side that needed TAVR, one case, yes. As early on. We didn't see the snare carefully around the tip of the aortic valve. Yeah. A little bit of it, just tiny.
Little can go a long way.
Thank you, Abdallah.
Thank you so
That's
much.
a great case.
Appreciate
Thank
it.
you. Next up is my work colleague, my previous work colleague and friend, Dr. Richard Bay, on fancy tricuspid imaging.
Paul always gives me these titles that are hard to live up to. So I just thought I'd show something a little different this time. So this is a 43-year-old woman who presented with severe TR. So she has a background of non-ischemic cardiomyopathy, severe LV dysfunction. She's on dialysis. She has lupus. She had a previous AVR, mechanical AVR and MVR, and a tricuspid annular repair with a 28 MC3 band in 2023 at an outside hospital. Got some opioid dependence on chronic methadone. And so she was admitted to our facility with right-sided heart failure, ascites requiring paracentesis. She had an RA pressure of 22, wedge of 20, moderate pulmonary hypertension, cardiac index 2.73. So our heart failure team worked on her, and this was her baseline TE. You can see the ring, but you can see this outpouching along the septum. You can see the leaflets are tethered down, and there's a lot of TR. So I've seen some cases with this outpouching before. Gorav, you as the surgeon, is there any surgical predictor of this? Is this wrong size ring or positioning or just?
And just to be clear, this is basically the annulus where there is not the ring. And so it's probably a function of somebody's downsized the remaining part, and it's not maybe it's some progressive dilation. Typically, we don't see it at the time of surgery. And so, somebody tried to downsize. And clearly, here's the other thought I have is sometimes at the time of surgery, at the first operation, a smaller ring is not the answer, right? Because there's so much tethering.
Thanks.
What type of ring was it? I saw 28. Was it
MC3.
So that's a very rigid ring.
Yeah. And so on the transgastric, you can see that the leaflets are just tethered down, very broad. Tricuspid regurgitation, severe, all along the commissure. And so, any thoughts about this, Nadira?
We were just chatting, the right ventricle looks kind of dead.
Yeah, on that X-plane in the upper left, that RV is big and very
Roosha, what do you think?
That
Yeah,
RV scares
I
me, I
mean,
can tell you.
I don't know what's going to happen even if you fix the TR. That RV looks really bad.
So obviously a challenging case, but a young person.
I mean, a young person who's on methadone, who's on dialysis. I
Yes.
mean, so there's also understanding what's the life expectancy. There have been publications in patients on dialysis that have surgical valve replacement. Their 2-year mortality is between 50 and 60%. So, and then you add in that she may have used drugs in the past. So there's other considerations.
One thing we haven't talked about is the impact of a bad LV when the RV is bad. Look at this LV. It's like, I think you can get away with a bad RV if the LV is okay, but here you have both. I mean, this is a setup for a real challenge clinically.
And so this is
I know I'm going to send all these cases to Richard, though, that's for sure.
and this is CT, so you can see the band and the unsupported segment and some measurements there. So obviously a very challenging situation, a young person. We had CV surgery, see the patient, felt obviously she's very high risk surgery. She had more volume removed with dialysis. She was on BiPAP and dobutamine. Those were eventually weaned off. So we discussed.
I ask you, did her RV look better after those maneuvers, or?
Not a whole lot. She did clinically improve, but the RV did not look a lot change. So we had a long discussion at the valve conference and felt that it was reasonable to proceed with the only thing that we felt we could offer was the valve and ring. So it was decided to try a 26 millimeter Sapien 3. And any comment about the sizing in that ring?
Well, anchoring, of course, and then a good amount of residual leak you might want to be prepared for. Either just have a plan in place, devices in place, or even set yourself up at the beginning of the procedure. Extra device in place, but anchoring and then fixing the residual leak are the thoughts I have.
I think you're at risk for a pretty sizable residual leak the way that
It's
outpouch
going to be there,
is.
just how you deal with it, yeah.
Residual leak, PVL, you mean?
For outside the
Right.
sapien,
Yeah,
where that
that's-
outpouch is.
That's been the historical
I think
experience
anchoring is
with
going to
this.
be okay, but
I mean, I don't know if we have a way of predicting that because it's just how much that C expands, right?
I mean, with certain ring, I mean, the MC3 is a very rigid ring.
Yeah, so if it
it's-
doesn't expand, then will you have
it's-
PVO?
So let's define PVL. So if you say PVL outside of the sapien valve, yes, but not. I don't think there's as much of a risk of PVL where the ring is. It's where that outpouching is.
yes,
That
where
I
the
think you're going to
outpouching-
have to be prepared for some type of device to.
We've had a pretty poor experience with semi-rigids with PVLs in the area where the ring is incomplete.
Where's the ring
Yeah,
is.
because you expand the ring and that area that's incomplete expands and you get PVL there. Here, I don't know exactly what's going to happen because it's rigid. So I don't know the answer.
I mean, I think, yeah.
Yeah, and I meant PVL where you're unsupported. Right. There's almost no way you're not going to have leak there. I don't even, probably not even PVL. It's just, whatever. Yeah, it's regurg.
So obviously,
But maybe that's a good pop-off for this bad RV.
It's intentional. I left that intentionally.
right. Maybe a little bit isn't bad. So, the concerns were, correct valve sizing, risk of valve malposition. I think we've seen cases where the valve kind of squirts out as it's being inflated into that unsupported area, and certainly the risk of PVL. So not a straightforward case. So the patient's on the table and has decent TE images, and so we do some measurements. I'm not sure they really help a lot. We get an area of 581, and so here's the color. It's just all over the place. So one issue is the wire trajectory. Here it goes into the pulmonary artery, and you can see it likes to take this naturally a posterior to anterior trajectory. Concern is like if the valve deploys that way, then you kind of have that anterior portion in the RV, which may make any PVL closure difficult. And so you would ideally like it more coaxial. So we did want to see what happens to the ring. Use the 26 true balloon just to see how it responded. And it seemed like it responded well. And you can see that there is with the balloon inflation, there is some PVL in that anterior region, the unsupported region. So we knew that we'd expect that. But we wanted to keep that hole accessible without having the cage, blocking that area with an anterior trajectory. You can see with the balloon inflation, it's still kind of that posterior to anterior trajectory.
Right, but you don't see, at least in this test, that leak in that area where you're unsupported. At least it's pretty small. Is that right?
Yeah, I mean, it's there, but it's not gigantic. You can see in the bottom segment there that there is.
Remember, they had trouble getting the wire into the RV, or why was the wire up in the PA?
Just initially put that way for support.
For support?
Yeah. But as you can see, we wanted it more coaxial. So initially, as the valve went in, it was in that posterior to anterior trajectory, as you can see on the left. But with some repositioning, we were able to get it more vertically oriented. And then once it was deployed, you could see that you'll see it better on fluoro, but it was at a more coaxial angle. So here's on fluoro, so you can see we got it more coaxial, and then starting on the posterior aspect. So we felt that would, by the time it got to that unsupported area, the valve would be mostly deployed at that point, and so kind of positioning we felt was good.
You just make a comment for everybody about where your goal to deploy the valve is relative to the ring. And remember, the ring is actually three-dimensional too, so it's not a perfect plane.
Yeah, I think it was.
Looks good.
Yeah, I forgot what the initial percentage was, but obviously.
Usually with the Ultra, the skirts are long, pretty forgiving. For us, positioning this valve, what do you think? Yeah. So 2/3, third, yeah, with 2/3 in the RV. Yeah.
And so with that, we do see the PVL. You do see it on the right side on the color. And here you can actually see it better on the short axis metaesophageal view. But it's the access looks better because it's coaxial. We did some measurements with MPR. We're able to get a wire across without much difficulty. And then selection of closure device. Anyone want to comment?
Yeah. Sashin, what did you use? Tell us, what kind of plugs did you put in here? I think you'd want to leave a rail too, an anchor wire, because I think recrossing this would be a bear. So, I mean, you're going to need more than one. So probably a couple of 12 millimeter AVP2s.
Yeah, it's Crescentic. I left it, deferred to my structuralist, and actually I decided to use a 27 Gore cardioform. But actually, it deployed pretty well. There's a small, here you just see the fluoro here, release. And in the upper right, there is a small residual PVL, but we decided to leave that alone. But as you can see on the bottom, the RV still looks bad, pretty similar to the baseline. But actually, clinically, the patient tolerated it very well.
Yeah, I wouldn't have either. But was there a discussion about the different options and you just decided with that one, or was that the plan up front?
Of
The Gore device?
No, that was on the fly
Yeah.
device selection, yeah.
Yeah, looked good though.
The risk there is that the lock may not get locked, and because when you stuff these in there, if the alignment is improper, then you can't lock the cardioform, and then you get really stuck. So hats off to was it Santo who did this? Yeah, that takes guts. I don't know, anybody else would have done a cardioform? Costas is saying yes. No. Ross, would you do a cardioform? I think it's impressive.
I'll have what he's had.
I'm just a simple echo guy, so I let them pick.
Marisha,
But,
what do you think? Would you do a cardioform? Yeah. AVPs? Okay.
How many do you think it would take, and what size would you use?
12.
Well, based on the fact that this 27 cardioform you still have leak, it's going to take 3. Yeah. Yeah. But you could stop at 2 and leave this as well, I guess. But
Would you deploy simultaneously, or?
I think, well, it depends on where your wire ends up. Because you can't create a rail into the PA, you have to leave an anchor wire. And so it depends on where your anchor wire. And so if your anchor wire is out in the PA, that means you'll start anterior. And so starting anterior, you should be able to sequentially hopscotch posterior. But that's how I would do it. Yeah. But I think this is great. I mean, I just impressed that the cardioform was able to lock and you're able to leave it in place.
So, you know, not that fancy imaging, but I think it was useful in the valve sizing, positioning and trajectory and PVL planning, assessment, and sizing for repair.
I would also add, so we did a case similar to this, and you highlight, I think, something very important. It's that trajectory, because our valve canted a bit, and accessing that was not as easy, so we decided to live to fight another day and see how the patient's doing, and they're not doing that well either. You know, they need this dealt with, but that you were able to align it a lot better than when we tried it. So I think that's really important.
Yeah, I think that's a great point. Paul and I were whispering to each other about the wire placement, because there's definitely a risk for skirt miss here. Even though it's very forgiving, the Ultra's 60/40, there's definitely a risk for skirt miss, and then you got another PVL to deal with. But I just wonder, you know, maybe the RV was too small or something, but getting a wire in the RV. And then the other is, would anybody have done this transjugular? Yeah. I mean, I wouldn't, but I know it always comes up. Yeah,
It's good approach, is what he's saying. Good. I mean, it's certainly more direct.
maybe, yeah. And where do you put your wire when you go in transjug? You still go RV. Yeah.
Yeah. He has his surgeon stand in front.
Okay, thank you.
Thank you, Richard.
That was great, Richard.
Firas, I think you're up. Good. Firas is going to talk to about his hardest percutaneous valve replacement in 2025.
Well, thank you. The year is not over yet,
Yeah, I
but
know. It may be a
I'll
different case.
say so far. So this is my disclosure, and I think that this is where we are when it comes to TR. I think we're divided. Some are chasing, some are running away. It's it's a new field, and it's very exciting, and it's definitely involved running. Imaging is critical in tricuspid. I want to get this out of the way for all of my imaging colleagues. You know, Scott is sitting here in the front row. Yesterday was all about imaging. And I got this picture. This is Scott here. I don't know if you guys see him. He's sitting, and it was very educational in the morning. And, this is the beginning of our case. Usually we're sitting down and we're reviewing cases very thoroughly and calm. And I think this is how he was in the afternoon. And this is how it is at the end of the case sometimes. So this patient is an 82-year-old female, had AFib, had a pacemaker in 2006, dual chamber, had a mitral valve repair, CKD, torrential TR, questionable lead impingement, lower extremity edema. She's on hefty dose of diuretics. And this is the imaging, the transgastric and the mid-esophageal. And this is the CAT scan. This is the lead. See the right atrial lead and the RV lead. Aiming a little bit toward the RVOT. And now, what is the treatment plan? TEER. Thought about TEER. Gap is big. Leaflet impingement. Tether septal leaflet. TTVR. We're going to jail the lead. The lead is do we remove it? It's an old lead, 2008. It's about close to 20 years old lead. And do we continue on the medical therapy? But she's on a hefty dose of Lasix. I just realized, staring at Gorav, that I did not put surgery. But she's an 82 years old redo.
Yep.
So
Happens sometimes, but yeah. Certainly, I agree with you. Look at these other options first.
any comment? You want to know what the tricuspid annulus is, and this is the sizing. Is around high 150, so it is suitable for evoke.
Any issues with anticoagulation?
No. Any watch outs? Recommendation based on what we've seen so far? No. So we thought it was evoke. We're going to put it at a fourth case of the day, and we'll do 3 evokes, and it's straightforward, right? And just put 52 valve, big atrium.
Ross, can I just ask that papillary muscles for diastolic retention? Can you explain that a little bit more? Here on your previous slide.
Yes. Oh, I'm sorry. Hold on. Talking about this slide or this slide. So
The planning slide for evoke.
Yeah. So so we look at the this is the papillary muscles. I mean, it didn't look necessarily super dominant, and neither on echo or on CT. But if you're in borderline sizing and the papillary muscles are inward pointing, it'll give you another layer of confidence that they're going to hold the valve up. So that is that is an advantage if that is the case. And in this case, everything seemed to be favorable. So what you get, what Paul is referring to, this is what you what you get. The comment is, where are the papillary muscles? In a way, if the valve end up being not so oversized, would the papillary muscle hold the valve so it doesn't go ventricular? That was not our issue in this case. So we do ice, and we do ice in a lot of our procedures, and we get ice going. Here we go. And we noticed that there is this papillary muscle that we saw on CT on an echo on ice looks a little bit more dominant. And kind of we don't like it, but let's just ignore it and let's just keep going. And we got the evoke valve, and then we spend about 20 minutes wondering where the capsule gap is. How deep are we in the RV? Is this the capsule gap? Are we that deep? Is this the capsule gap? Is this the capsule gap? We're really not sure. We tried a couple maneuvers, tried to figure out where the capsule gap is. We looked at it on TEE, we looked at it on ice, and we injected saline to get the bubbles out, and we could not be determined where the capsule gap is. Couple things noting on fluoroscopy to get to this point. Notice the tortuous venous anatomy. We came from the right. You see the ice was going from the left, but you see this tortuosity in the venous anatomy. And as we got the the valve, you can tell looking at the mitral ring how deep we were. So yeah, we're wondering on echo where the capsule gap is.
It looked like it was deep on the echo.
But on fluoroscopy, it looks like we're very deep. Do you remember that case, Scott? Yeah. At this point, it's 7 o'clock, and the fourth case of the day. And it was like, okay, let's just push the wire. We know how to do that very well. So we decided to push the wire. Notice how much push on the wire. We flipped the anchor, and now you see where the capsule gap is. You see where the anchor of the valve, came. Maybe we're above the papillary muscles. We thought that, maybe it's okay. Any comment? Is it good? Not good? Are you expecting to see perf on the next slides? Any comment?
It's a redo, so you're a little bit protected.
That's right.
I am curious, though. If you had I'm not sure when you actually figured out how deep you are. I think in retrospect, it sounds like you can see it on the very first echo. It looks like there's something in the RB. But on fluoro, if you had that suggestion, you hadn't flipped yet.
Yep.
Did you know then, or do you decide to proceed, or do you try to go to the other side and that gains you some height?
Yeah, that is a very good point.
Was that
on
a discussion?
CT, the atrium was so big, so we did not expect that. We thought just by pushing the wire. And I will be honest, at some point we were fooled where we thought the capsule gap is, and we thought it was higher than it actually was, and until the anchors were exposed. So at that point,
So it wasn't until this point
correct.
that you knew.
Correct.
But
But
it's
if
really,
you did, has anybody ever then swapped sides?
we
before
have-
you get to this
we
point,
have
right?
for heights, and so if you look at the image on the screen right there, you can actually see the difference, right versus left, right there. So if you're going from the right, the catheter, which is coming from the right, is on the left side, and you gain almost a centimeter or two. It's quite remarkable.
And I think the angle too can be favorable.
All right, so now we realize that we're too deep. And, after full ventricular expansion, it's too deep. And, like every intervention cardiologist, we said, well, if you don't like it, just try to pull it out. So we tried to literally pull it out. And hoping that we have enough leaflet engagement that as we're pulling it out, it's just going to engage, with the valve. So we're literally trying to walk the valve out of the body, and hoping that we will be able to, get it a little higher. That's why you notice we were able to get it a little higher. We had a little trajectory, but we're able to get it a bit higher. And now if you go to LAO, and you'll see that we are also, on the other side, we have a pacemaker. So we were in between the papillary muscle on the lateral side and on the pacemaker on the septal side, and both of them are creating an unfavorable rail, for the valve. And I think that this is how we got stuck in the subvalvular apparatus. So we tried all of those unsuccessfully. We tried to put a sizing balloon, hoping that we will push the delivery catheter backward. Did not work. We tried to snare it and pull it to gain height. Did not work. We tried to wrap the ice catheter on it and put dorsiflex on the ice catheter. Did not work. We tried to push the wire, as you can see. That did not work. And we did a lot of cursing, and that did not work either. So we just like, okay, let's just release it, see what happened at this point. Like, there was nothing to do. So we released it. And you see how the valve is like bobbing. Posterior dial. Now, not now, now, not now. You see the pacemaker is on one side, and this is the echo. You see that papillary muscle that we were worried about, and there's a lead on the other side. And this was after partial release. Now, notice when, when we were releasing it and we saw the valve start bobbing like this, and we saw this picture on echo, for whatever reason, froze. It's like, okay, what is going on? And we noticed that we're still hanging on the valve. So we decided just like to push it. So we pushed it, and it started going up posteriorly, and we pushed it more and started going up posteriorly, and we pushed, and there was a lot of pushing that was not stored. But we created this axis between the tip of the nose cone that was on this side of the valve and the delivery catheter that's pushing up, and all what is hanging on to one strut of the valve. That is all what is left. And you see that orientation where it was completely in the valve, was now adjusted. So don't recommend that, but this is what we end up doing, and this is my hardest case in 2025. So after all of the pushing, we were able to get the valve in the position that you want, and notice how the pacemaker on one side and the papillary muscle on the other side was creating this rail. And from the amount of pushing, the PVL is gone. We fixed the position of the valve, but because we were doing a lot of maneuvering on the leaflet, there was a valvular leak. So the complication was, do we put a sapien valve inside of this? And this is going to be my hardest case for 2026 because we did not do that, and we brought this patient. This is the 30-day echo. The leaflet warmed up and recovered, and the PVL is mild, and the valvular leak is mild, and the patient is doing, really well. So this is an entrapment of TTVR. But I want to say, just for completeness, it also happened with TEER. This is a case that we put a TEER device in. We got great results. We clearly did not have leaflet. The following day, the TEER SLDs from the septal, and we were probably hooked on some valvular chordae. And we treated this case with Evoke jailing the Pascal device. In this case, this is one of the first cases that was done in 2020, and was published. So to conclude, tricuspid valve is complex. We need to understand anatomy. Left groin is effective. I wish we switched to a left groin early. Respect the lead. And I'm pretty sure that future development will solve these issues with capsule gap or depth or whatever by some iteration in the delivery catheter. Thank you. And thank you, Scott.
So Firas, in retrospect, how many anchors do you think you actually got on the leaflet for the Evoke? Because it certainly seems quite deep compared to normal.
Yeah, I think we got enough, whatever that number is.
Or was it mostly it almost to me, and I welcome the imager's thoughts, but looks to me you primarily got the papillary muscle or the cords on that dominant side.
Correct.
And the rest of it is staying in place, and there's not much TR because it's acting almost as a spacer. It's filling the space, and there's obviously the valve's functioning, so the flow's going through the valve, but that's what it almost looks like to me.
Yes.
I would like to know, Scott, what was going through your head at that time?
I want to say that most of the cursing was from him.
Step two is, the beauty about this was with ice. So usually as you're inflating that valve and you're on TE and you're kind of the last final inflations, you're pretty limited in what you're able to see. But with ice there, like we saw this jump as it was going. So then it's just really paying attention to that and then just calling out, oh God, stop. Like what happened? Something bad happened. It's like, oh, I just go, but what was that? And then people kind of stop. So that was helpful because really once you have it in place, it's just like, okay, great. You're gonna inflate the thing. You're gonna release it, and then I'm gonna do my thing afterwards. Like I'm paying less attention to that, but the complexity of this case, you just knew you had to stay with it the whole time. So I don't know how I make it through those. I just somehow do.
And Roosha, how about, in terms of imaging from CT, like to Firas' point, us imagers understanding even from TE, the subvalvular apparatus, the papillary muscles, any thoughts on that?
I think, you know, the more cases like this we see, the more we realize we really need to start commenting more on this and not just do, you know, plain old measurements. It's kind of like where we're moving with TAVR and, you know, looking for coronary obstruction and, you know, lifetime management. I think we need to start having that similar approach to CT for tricuspid as well. I had a question. Are you going to follow up echoes with this patient more frequently or just standard of care?
So, I mean, you know, call it limitation of technologies, call it advantage of technology. But I mean, in reality, we were able to, as Gorav was saying, we were able to, you know, probably my guess is we have a lead that we engaged on. Of the 9 anchors, we probably are engaged in 4 or 5 maybe. And we definitely, the rest is not engaged. You see flow forward, but you don't see TR because the leaflet, you know, seals it on the, you know, on the valve. You know, the valve position was stable, and you know, we were able, even at the final stages of deployment and beyond, able to adjust, you know, the position of the valve. I mean, initially it was just rocking, wanted to, you know, dislodge, but by able to push it, we were able to, you know, to seal it in place. So I think this is one of the earlier commercial experience. And I think the lesson learned is exactly what you said. You know, don't let your guard down. Look at the papillae or look at the RV. You know, do every case like it is your first case. There's definitely, you know, at this point we were, you know, we started feeling very, you know, comfortable and maybe let the guard down in some of the.
I bet if it was your first case of the day, it might have been a different outcome.
It might have been.
So that's the other thing. There's some data on how, you know, how we get fatigued. But I was going to say, I do wonder if you might see even more positive RV remodeling because now you're not pushing against the base. So let us know what the RV looks like in the future.
I have to say, I was quite impressed with how forgiving everything was.
Yep.
Because honestly, I thought it was going to be an RV perf. We've pushed less on RV free walls and had worse perfs. So I thought there was redos or what? Yeah, actually, in others. Yeah. So it's actually, you're right. I don't know. Maybe there was a tiny perf that maybe, but I thought the nose cone was going to be an issue. And then the other thing that was quite forgiving was, despite how much anchoring you were pulling against, the atrial side of the device held. Yep. Such that it didn't malposition into the RV. Yep. So I actually was expecting it to be in the RV when you're done. So that was actually quite impressive. So
yeah, I mean, I think the you know, I wish I can tell you we knew exactly what's going to happen. I mean, there's a component of it where, you know, we're trying, you know, anything that you know, that we can. But I think your point is you know, very well taken, Paul. I think the most important lesson for us is low threshold to go left. It definitely make a difference. I mean, if you look at the trial, it was like, what, 15%, 10-15% left. And I think in clinical practice. And especially in this case, I thought hard, do we show the fluoroscopy or not? Because Paul's going to tell me, look at the ring. And if there's a mitral ring, you can see how deep we are. So looking back, we probably should have switched the left. It make a difference.
Thank you so much
Thank
for
you.
us for
Thank
a great case. Thank you. And it's my great pleasure to introduce again Jonathan Schwartz for his case on large gap therapy with tricuspid repair.
Great, thank you, Nadira. Okay, so for this one, Paul took away the easy button for me. We have to stick to repair. We're not allowed to do the evoke here, so thought it'd be a good case to go through. This isn't working. There we go. Okay. A 78-year-old woman with AFib, some hypertension, ulcerative colitis, another GI bleed. This was another one that was originally referred for a Watchman. We tend to get a lot of patients that way. And during the TE, for pre-op, or during the case was found to have severe TR, had some multiple hospitalizations with fatigue and anasarca, was referred to us with pretty bad dyspnea. Ascites was her main issue, and then just kind of overall failing to thrive. Pre-procedure, so this was during the Watchman. You can see the Watchman looked good, but pretty bad TR. So was first optimized, was thought to be what was told to be a euvolemic, was referred her to heart failure to a med titration clinic. They did as best they could, push the diuretics until her creatinine started rising. still had symptoms despite this. Then had a specific structurally focused TE done and an MRI and then our right heart cath and get some labs. The RV looked okay on the MRI, definitely had severe TR. You can see the numbers not so bad on the right heart cath. Pressure's all relatively normal, but you'll notice the cardiac index here was 1.3. Here's the pictures, so pretty broad jet there for TR, the on-FOS view, also pretty broad. Checking the leaflets here, able to visualize things pretty well. But lots of TR, even though it was told to be optimized. You can see somewhat of a little bit of a canyon in there, but the gap was measured to be about 13 millimeters. So in summary, torrential TR here with some annular dilation and some leaflet malcoaptation, large valve with a large gap. RV function seemed okay. The PAPI was 1.3 with a poor cardiac index. She was not able to take oral anticoagulants, so evoke was not an option here. Panel.
What would you do, Richard?
Well, it looked like you had kind of a favorable anatomy in that anteroseptal commissure from your transgastric short axis view to try a zipping clip. Yeah, on that left side.
Mm-hmm.
So I think if you you could start, more commissural anteroseptal and then kind of work your way back, and that might help bring in the gap a little bit. So I think it's approachable, but certainly not a green zone.
And would you just kind of plan on having a lot of TR at the end, or what do you think?
A little bit unpredictable.
Yeah.
I think what's on your side is that it's a single coaptation plane. And so if you can pull that septal leaflet over, I think that helps. And then the other thing too is that your right-hand image, the leaflets are not too curled. And so they're pretty flat or symmetrical in terms of the leaflet tips, which means your gaps are probably as small as they could ever be. So I think starting anteroseptal, as Richard said, Nadira, you agree? And probably just seeing where that goes, but it's going to be very important not to anchor the septal leaflet too much with the clip.
I mean, if as best euvolemic he is, probably that's your first step, try to get as much out, helping with, reducing the gaps probably, but that if that's where we are right now, then to what Paul's point, getting that first clip, the anteroseptal, and seeing how the next step, how that septal leaflet posterior to it behaves, and whether you're pulling it in. So,
Yeah.
I think to your point, making sure the patient understands what your endpoint might be, setting the right expectations is really important because you just don't know.
Yeah, for sure. Does that low cardiac index worry anybody?
I mean, it's still safe to do. I don't think the low cardiac index is too bad. I haven't heard anybody say anything about the RV. But I look at that in the context of the fact that they're a little dry and the PA pressures are not high. So I think you're going to be okay. Was it calculated with FIC or thermal? Do you remember?
It was FIC.
FIC, yeah.
And I guess I would say the RV looks better than what that index would suggest. So I don't think I would get too concerned about it. I mean, you're going to leave some residual TR anyway.
Don't worry too much. Yeah. Okay. Helpful. Keep moving. So just to make sure we're all on the same page, there are multiple publications now looking at PAPI and tricuspid interventions with pretty poor outcomes. So like you guys said, though, we thought, well, it is low, but the RV looks okay. She was desperate, so we thought, it's a safe procedure. Why not give it a chance? So not a candidate for evoke. The gap was initially thought to be maybe.
Why couldn't she tolerate anticoagulation?
GI bleed, multiple hospitalizations with GI bleed. Yep.
That was with a new agent as well.
Yes. Yep. And how she got to us was Watchman. So, yep. So we were wondering maybe she wasn't quite truly euvolemic either. So the plan was to do a pre-admission for another right heart cath and some diuresis, and then if things looked good, we could go ahead. So at her pre-admission index was still about the same. Numbers still not too bad. Some thought that maybe some of the index, she had some kind of bradycardia, nothing like complete heart block, but we thought maybe that was part of why the output was a little bit low. So after 4 days of diuresis, the TE showed the TR actually had improved quite a bit, down to moderate to severe, but still pretty bad. And the RV function was still okay. So we thought, well, let's get her on the table and screen, see how things look. And the gaps looked a lot better, actually, down to about 8 or 9 millimeters from 13. Still significant TR. Went through, started just like everyone has suggested at the interseptal commissure, went pretty far down, zip and clip strategy. First clip went pretty quickly and was good. Still had significant TR afterwards. Ended up doing a second one right next to it. And that was much easier with that first clip there. Brought the leaflets a little bit closer. Got the clip on and still had some TR, so went in with a third clip and got the TR down to basically trace. Things looked really good there. You can see it there as well. Used both TE and ICE for this case. Got some good cases. You can see again that bringing the ICE probe around with the candy cane really helped. Despite the 3 clips, gradient was still only 2. It was a large valve to start with, so we weren't too worried about that. But things look pretty good. So what was initially thought maybe exclusive anatomy to do clip, we were able to get a good result with some extra diuresis and brought the leaflets together. I think being told someone is euvolemic is not always true. So the prehab, it's been mentioned many times today, very important, I think, for getting the best result possible here, involving heart failure colleagues and everyone else. And then again, imaging for sure played a big role here. So thank you very much.
Thank you.
Thank
So I guess this is a question for you, John, as well as the panel. You know, we do a lot of prehab, or make things that were not feasible more feasible, and then they go back out and, you know, get back to whatever their new euvolemic state is, which is presumably better than it was when they came in, but may not be as good as when you discharge them from the hospital. Have you guys seen patients TR look a little worse? I mean, we certainly have, you know, in the 1 month in the post-procedure setting. And how do you try to manage that?
Yeah, it's a bit variable. I think the result you get at the end of the case really plays a big role in how the next steps go. All of our patients get 1 week, 1 month follow-up at the minimum. And then if they're doing well, we'll continue to follow them if they need to. The heart failure clinic can follow them as well. In general, it's been pretty durable. We've been very impressed with the results. So.
Great case, Jonathan. I want to also ask Marcus, your imager,
Yeah,
any comments? Is right there for this case. And in terms of, Marcus, the imaging workflow during the rehab process, right? I mean, how long would you recommend to, you know, to psychs, you know, in terms of when to repeat this imaging?
So this was, you know, first of all, the main point of this was that people were saying, oh, the gaps are too big. So we want people to understand that that's kind of more of a thing of the past, right? Like, we've learned that whether it's prehab or zip, not that I want to use the terms zip and clip strategy, that this is, you can bring these edge-to-edge repairs and have quite good success and have the annular area come in along with the valve area shrinking and have better coaptation. In terms of this patient, you know, some of the decision on how quickly you need to do things is based on how poorly they're doing. I think this patient was, you know, chugging along with, believe it or not, with a cardiac index of about 1.3, and we were able to get her through, and we just did it. I think it was about 3 days of, did you say, of prehab, 3 or 4 days, and we were struck when we started the case at how much those gaps shrunk, and I'm sure you guys have seen this all the time. So it was impressive, and then the case was actually pretty easy. And then to say you walked away with trivial TR on someone that was torrential in the past, you know, here's the other thing too, is you saw the TR was not that bad to begin with. To your point, you say you bring them back, they get worse. I think we need to be a little, maybe if we have a lot of valve area and safety to work with, that we probably need to put on some more clips than we think, because you know they've already been able to have torrential TR. So we really wanted a good result when we had the opportunity to achieve it and not have high gradients. Hopefully that answers your question, Nadira.
Do you want to just talk a little bit about your prehab program? Because we're throwing in the word prehab, but I am not sure exactly
Me
what all
either,
we're doing
and that's
here.
why I'm going to hand it back to Jonathan.
Jonathan, okay. Can you tell us a little about what you do?
Yeah, so it's not really standardized for anyone, but it's a referral to the heart failure clinic, and then there's a med titration clinic where it's mostly done virtually or over the phone, just checking every day about doses and what their weights are, and labs if you need to. And then for cases that we're worried about, we'll pre-admit them. They'll get a right heart cath on the day that they come in, and then it's usually at least 3 days, if not a couple more, depending on how bad the numbers look before the procedure, and then we'll screen them on the table.
Milrinone, dobutamine, Lasix strip.
Yep, if we need it. For this case, I guess we probably could have, but she was diuresing pretty well, so we did not add on any inotropes, but when we have done that before, yes.
And you typically just do a cath, you don't leave a swan in.
If it's someone that needs inotropes, then we will leave it in, yeah. Yep.
Gorav, you do inotropes before surgery in your prehab?
Not very often. Most of ours are right heart cath admission,
Similar
and then
than what we do
diuresis.
for transcath.
Yeah, and so, I think if they're that bad, then we potentially already screened them out as a surgical candidate, depending on the situation.
So what do you guys do for your prehab?
So it's been a little mix of everything, not a formal program like this, but yes, right heart cath, the diuretics were needed. I can't remember too many patients with inotropes.
I was just going to add one more thing. I think, a lot of people refer to success of procedure related to gaps, and then we talk about prehab and other options. There's gaps and there's gaps though, right? There's gaps with mobile leaflets, and there's gaps with tethered leaflets or pacer leads, and you've been talking a lot about leads today. This case was a case of big gaps, but with mobile leaflets, so it gave us all the more confidence that this was going to be doable. So I think even the gaps, when we see they're huge, it's somewhat, you have to consider the company it's keeping.
We often talk about functional gaps versus anatomic gaps because on the transgastric view, the shortest distance is anatomically small, but when the leaflets are tethered, they're functionally much wider. And it's the leaflet edges we're trying to get underneath the device. Yeah, for us. We need some more mics for the audience. I don't know if you guys have some back there. You could pass them around.
I mean, this is a phenomenal case. I have the world experts in tricuspid and TR. We talk a lot about what is the strategy? What should we do? Do one device at 9.3, posterior, anterior, and almost every case we end up putting anterior septal device, and if needed, another device. Is this the practice, everybody? Can we just say that in most cases, this is what the strategy is going to be, an anterior septal and maybe another device posterior to it, or we're not there yet? I mean, are we still thinking that maybe one device in the middle, if we can, septal lateral, whatever, septal anterior, septal posterior?
We've evolved.
Yeah.
Richard, do you want to talk a little bit how we've evolved in that way?
Yeah, I think, we used to just go where the regurgitation was. Sometimes we just put a PS clip on, but I think that the data shows that a vast majority of cases involve an AS clip. So I think that's pretty much become more of the standard.
And sometimes we've buried them in the AS commissure, starting there because that's the easiest. It's the smallest gap. It's the easiest just to throw one in. But honestly, I've been a little more wary of that because if you go in the AS commissure and you anchor the septal leaflet, it makes the subsequent ones harder. The only exception to that is if they're all in the same plane. So if it's a single coaptation plane, then you can just zip up anteroseptally. But if the coaptation is more curvilinear, or if it's more of a starburst, you anchor the septal leaflet, it makes everything else harder. So then I tend to go more central as much as possible. I like the A-frame, in my opinion. A-frame or clover. Mark, what do you do?
No, I think same, but I think there's no question about septal anterior. It's just where septal anterior start. In our view, we often will talk a little bit about doing other, but when push comes to shove and device is going in, we're going septal anterior. It's just whether it's mid or central, or of course commercial. And then we often will close the device with that transgastric view and get a really good sense of how much of a annuloplasty effect you're getting. But I think that's where you get most of it. and then toy around with going more central or then septal.
That's the reason it's the annuloplasty. All right,
And we
good.
see that from the Triluminate data, which will be coming out on that soon. So in the interest of time, thank you so much, Jonathan. Let's now invite Dr. Manny Vannon for our last case before lunch. He's going to be present on leads and tricuspid success. I think you've seen a lot of cases of leads today, and he'll tell us how to make it successful.
He's saying no.
can go to lunch now. No, I'm not doing leads because it's a pain in the
Got a
neck.
better topic. Probably baseball.
I'm just going to show, I told Paul, I'm going to show how we do evoke with
yes,
only
you did
ice and
say
mac, no TEs. I think esophagus was made for food, not for TE. I think we hijacked the esophagus for TE.
Leave it to the guy who just came off the beach to make the smartest comment.
No, but seriously, I mean, I think esophagus, if you ask the esophagus how it feels after TE, I think you'll be shocked. It doesn't feel good. So my PowerPoint does not work, so I have individual movies, and the lady at the back is going to help me bring up one at a time in sequence. So we do evoke TTVRs, no general anesthesia, MAC, and only ice, no TEE. And I'm just going to show you a sequence of the images of how we do it. I'm not saying, it certainly has made my life better. And quality of life generally improves because all this is done by our interventionist, and I have to give them credit for it. I'm not even in the room. I don't even know when they do it, but they do it. And it takes about 30 minutes and they are finished. So this is the home view when you put your ICE catheter in the RA. And as you can all see, the image on the right side does not have the same quality as the image on the left side. And that is a problem with the current generation of ICE catheters. It doesn't matter what ICE catheter you're using. The orthogonal view does not have the same resolution as the primary view. Number 2, please. So that's baseline. This is a 71-year-old having TTVR for tricuspid regurgitation. This is color Doppler. You can do color Doppler. Number 3, please. Number 3. I just noted.
If you notice that shutter that you're seeing there, that's the TR blowing on the ICE catheter during the image acquisition. It's true.
No,
That
it is
happens.
true. It is
It's
true.
true. That shutter.
NPRs. I'm not a great fan of NPRs, but we do NPRs because everybody else does it. I get my reimbursement, my salary based on NPRs, so I do NPRs. You can do NPRs with ICE, just like you do with TE. The quality of the volume image, of course, is not that great on any of the ICE catheters at the present time, but you can get decent 2D views out of the NPRs, reasonable. It's not always like this. I'm obviously showing my best case. It's not always this quality, and you do struggle with NPR sometimes with the ICE catheters. But the volume quality does not matter as much because if you're doing TTVR, it's more about spatial location rather than looking at the leaflets. So we're not too concerned about that. We just want to make sure that the 2D planes have reasonable quality. So this is at baseline. Now, I forget the number, so you can go to the next number, please. We do a perimeter planimetry that you can do like you do for with TE prior to the procedure. The next one, please. Spectral Doppler. Next, please. I'm not doing any of this. Our interventions are doing. I don't think you need an imager at all. You can do without an imager. I shouldn't say that, but that's true. Next, please. You can go to the next one.
You're assuming we know where the power buttons are
Oh,
on the ICE machine.
They actually do all of this.
Yeah, we've also taken away your microphones, Nadira.
No, thank you. I want to know how many sites, I think layers in the audience, sorry to put you on the spot, but how many sites besides PMON are doing
I don't know.
You know, do you have any now? This commercial. I know.
I have no idea.
Love the
but
Piedmont team.
I'm standing up here by myself. I don't know. I mean, does anybody? I don't know.
You
don't
guys
do it?
used to complain, you don't get paid, you're there for hours, now you can be on
I
the
don't
beach.
complain at all. I'm here.
That's right.
And they actually did too this morning
You
without
can still
me.
read
so
it, just from wherever you are.
They don't even send it to the Echo Pack machines. They send it to their own cath lab pack. I don't even see these images. I just downloaded this to show you. That's all. And there is the wire across. You can see the wire in the Safari wire in the RV apex. You can see it grossly. I mean, it's not the clearest or the prettiest picture, but you can see it just like TEE. TEE imaging for tricuspid valve can be as challenging. So I don't really complain about the quality of these images. Next, please. And then you have the valve delivery sheath, the valve delivery system, I should say. Next one, when you can, open the next one. There are just a few more videos I'll show you. The valve deployed. There is the valve delivery system across the. So they use a lot of fluoroscopy and they use ice when needed to visualize where they are in terms of beneath the valve or not beneath the valve. So that's what they use ice mainly for. Next, please. And after that, you can skip a couple of videos and just go. It's lunchtime. I'm sure I'm standing between lunch and there is a valve half exposed. They're comfortable with the location here. And then you can skip one and go to the next one, please.
As is coming up here, Manny, you mentioned in the beginning the orthogonal resolution. Or I've asked earlier, maybe we don't need all the anchors. I mean, the orthogonal resolution, I mean, how do you do the spin to account for seeing your all the way around when you have limitations on the orthogonal?
They do the spin, and I don't see anything. I believe they also don't see much in the spin because of the quality of the images, but the Edwards people always see something in the spin. I don't know what they see, but they always see something. And I have no idea. I've given up on it because I'm not that smart as they are. So this is the valve fully exposed. Again, look at the orthogonal view. It's not that great.
Orthogonal here, you're not going to see anything.
It's not that great.
Yeah, and the spin, you're not going to see anything in those views either. Yeah.
Next, you can go to the second last one maybe, where it says deployed color.
Do you have any of the spin?
I did download a still picture of the spin, but I don't remember the number.
Okay, that's.
I'm sorry. I can show it to you. The spin was hopeless.
Okay, we believe you.
This is after deployment, the MPR and the volume view. And then you can go to biplane, something that says biplane. I don't remember the number. And
The
this,
good news is if you can't see the valve deployed, you can't see the TR that's left either. so
on
you're
fluoro,
fine.
yeah, don't forget, I'm not showing you any of the fluoro. You can do a lot of this stuff by fluoro.
I imagine they're doing a RB gram at the beginning, just to sort of
Yes,
position. Yeah, yeah. So
yes,
that, I
yes.
mean, all that is.
And this is the valve deployed. Not bad. They're imaging and doing this. I'm really happy they're doing this stuff.
Part of this too is that your ice catheter is very close to the tricuspid valve.
Yes, it is.
So this is also a case where you might switch left versus right. You know, so go left with the evoke and right with the ice to get the ice probe really close, because otherwise the resolutions.
They do the ice on the right.
On the right, yes.
Yes.
Yep, that's exactly right. Because if your ice were coming from the left, I bet your resolution would be even worse.
There is one thing that says single plane, and then the last two videos pre-discharge or something it shows. I just do want to show you a couple of transthoracics after the deployment. just a wide sector of color, just to show no PVL, no significant PVL anyway. I can't see any PVL there.
Manny, how
We've
long?
done about 15 of these now. For the last 4 weeks, I'm not going into any of the evokes. They're doing it by themselves, and they tell me that the results are great. And I do look at the transthoracics later, and they are good. Can we go to the pre-discharge color, the very last one, please?
How long did it take for these cases?
30, 35 minutes. They do 5 a day. There is a good valve picture too, but I didn't want to waste time. So I'm just showing you the color. There's no significant PVL, or at least I don't see any PVL there. So this is how we do evoke now. And I'm not saying this is for everyone, but at least I think the future of imaging for TTVR may get even easier with better technology with ICE. And I think it's coming. I've seen better ICE technology already in the works, so I think that's coming. Thank you.
Do you guys think this is the future? Everybody, any concerns, put it this way?
Honestly, if they fix the lateral resolution, 100%, because it just needs to be a square crystal or a mini TE probe size. And if they fix the lateral resolution, there's no reason to think that we would need TE.
It'll be a bigger French.
Bigger French, yeah. And
It'll be a 10 French. I've seen one with 10 French and a square.
Well, as interventionists, we'll take 30 if we can get.
But the good thing is you can image the left side from the right side. So you can park it in the right atrium and image the mitral valve.
Yep.
So do you have a sonographer operating the console, or is it who's operating the manipulation?
Edwards people right now. But I think it's going to be one of the cath lab techs or whatever. They are so familiar with it. So, and I think there's technology coming, Richard, that I've seen that even the operator on the sterile field, you have ultrasound controls that you can control the machine.
Great. Well, thank you very much, Manny. That's a glimpse of the future, and I'm sure we'll see many more next year of us that are trying this that we learned here. We'll go to break and invite everybody to come back after lunch for the mitral sessions. Thank you.